our first topic is the management of submacular hemorrhage during vitrectomy for retinal detachment. So this course will highlight on the complications which occur during vitreoretinal surgery and how to manage it and how to get a successful outcome, and is probably useful for those young budding vitreoretinal surgeons, and I think all of us must have faced these complications. So we'll talk with our first topic. We'll start with Dr. Ajay Arora. I think he does not need any introduction. So sir, please start with your topic on the management of submacular hemorrhage during vitrectomy.
Thank you, Bhuvan. And good morning, everybody. Good morning, Vishal, Dr. Lalit, Dr. Azad, if he comes. So my topic is on submacular hemorrhage during vitrectomy, how to proceed. So the submacular hemorrhage can occur because of an inadvertent retinal damage, bleeding while peeling a vascular membrane, doing a drainage retinotomy, relaxing retinotomy, or when you get a subretinal bleed while doing a drainage for SRF in a scleral buckle. Now you must pay attention to unusual bleeding. Why? Because whenever there is bleeding, it clots and it forms a membrane. And it forms a membrane, you have to peel it. It may compromise your view. It can go subretinal. So what are the steps which you should take as a preventive measure? You must make sure that the patient's BP and heart rate are controlled. Initially, when the bleeding occurs, you have to exert mechanical pressure, maybe with the tip of a cutter. You can raise the bottle height, you can inject PFCL, remove the blood from the macular area, which is away from the macular area, or you can switch to air if you have done the dissections towards the end and complete a vitrectomy under air. You may add thrombin during infusion and can also add adrenaline during infusion. So this is just to show you how when dissecting out a vascular membrane, we can exert pressure with the edge of the cutter. There's a bleeder running, but if I exert the pressure, I do a proportionate reflux under the membrane, create a passage. You can see those bubbles. You will be able to avoid injuring the membrane, and you can easily remove this membrane. So this is just to show you in a vascular membrane how to avoid bleeding occurring on this thing. If a bleeding occurs, you can actually with your cutter use a proportionate reflux, wash out the blood before a membrane forms. In case there is a bleeder, you can use a chandelier, use a thermocautery at the same time. So you can visualize, you can remove the blood, you can aspirate the blood, and also use cautery for that. So that will help you. And as I said, you can also use endo laser in addition. You can do dissection under air, and you can use a PFCL assisted dissection. There was a small study which was published way back. We don't use it often, but I think it has a relevance, is to use bovine thrombin. People have used human plasma thrombin or a recombinant thrombin, because recombinant thrombin doesn't have the problems related to diseases, viral infections, and can be very, very useful for controlling bleeding on the table. This is just to show you some videos. You've had a bleed, you can see here. You had a bleed here, which is a large one. We injected PFCL, and then you can, there's a drainage retinotomy where you can go inside either with a soft tip or a hard tip, or with an end gripping forceps, and remove the heme, do a PFCL siliconal exchange, do endo laser, and you are absolutely done. So this is another patient where there's a large subretinal bleed which is dragging onto the macular area. Do a drainage retinotomy superiorly. You can see a retinotomy is being done. A soft tip has been put in. PFCL has been put in over the macula to displace the blood from the macular area. And then you remove this heme with a soft tip, do a fluid air exchange, remove the PFCL, add silicone oil, do endo laser, and you're again done. So you have to get in early, remove the blood before it clots, and do the needful. In case the blood has clotted or there's a large blood, this is what I got this video from Dr. Subhendu. So it's a large vitreous hemorrhage with a subretinal bleed, I'll just show you the part which we wanted to show, that you can create a large relaxing retinotomy, go in subretinally, and remove the blood by an end gripping forceps or a soft tip or a hard tip again. Once the blood has been removed, again fluid exchange, silicone injection, and it can be lasered in the end, and it works fairly well. These are some of the cases which is a dreaded complication of large suprachoroidal hemorrhage. I'll not discuss much into this, but we have treated a large number of them referred cases where you can drain it by putting in an EC maintainer, a partial thickness sclerotomy from outside, and then inject PFCL into the vitreous cavity, do the vitrectomy, remove the blood, and these are some of the examples. So the take-home message is, must plan well preoperatively, have a good systemic control, address any bleeding during vitrectomy immediately. There should be liberal use of perfluorocarbons. Infusion pressure must be elevated for a short duration of time till you can control the bleeding. May need to close the port. Fold up your hands. Do not panic. Plan for the next steps. Judicious use of thermocautery and simultaneous aspiration while you're doing a thermocautery. Therefore, utility of using a chandelier in these cases is very useful. And in severe cases, you can always close up, go back another day, and intervene subsequently. Thank you.
Thank you, Dr. Ajay. Any questions from the audience? We've got lots of time. So,
sir, any tips to remove the clot that forms? Sometimes the clot forms on the posterior pole by the time you finish a membrane dissection. So, like any tips to remove that safely without tearing the retina below?
Forming on the retinal surface. So the best way is that you remove the clot before it forms, but many times it does not happen. So what I do is that there are 2-3 ways of doing it. You could either support the retina adjacent to that with PFCL, take an end gripping forceps, create an edge. But what we have found out is that you should actually, if you're using a constellation or any other machine where you can have a reflux, proportionate reflux, you have beveled cutters available now. Go close to the blood, and then there you perfuse fluid. You create an edge between the retina and the clot. Once you create an edge between the retina and the clot, you can. So I'm presenting a similar thing tomorrow in retinas, where you can actually, I didn't wish to present it here. You can create it below the blood, and the whole blood will come off. So a counter support with PFCL with a minimal traction without causing force on the retina. So I hope you can imagine that. So either use end gripping forceps or this, any of these things can be used.
So I would just like to add something with Dr. Ajay has said. I think sir has highlighted everything. So one set is important here, we should try to prevent the formation of this by using PFCL as early as possible. But once you have formed a clot, which is involving the fovea large clot, it is very important to remove that clot, which will cause the loss of vision. So there is one more way in that you have to create a retinectomy, inferior 180 degrees or a temporal 180 retinectomy. You reflect the retina and then you have to remove that clot. So this is one way which has been described during surgery, because you just can't leave a very large clot at the posterior pole. So, and I said, sir, I don't think it will, with this technique would be better, but what you do is, which is conventional, which has been described in textbook, that you create a 180-degree retinectomy, you reflect the retina, remove the clot, and then with PFCL again settle it and go forward. This is I'm saying for a huge clot which is present at the posterior pole. A minor streak or something, better avoid it. Don't do anything. Leave it alone.
Subsequently, you can always use tissue plasminogen activator. And that inject it in the vitreous or subretinally. What I have done unconventional, I wish I had the video to show you with 2 cases like that. So I created 2 drainage retinotomies. I created one retinotomy from where I perfused fluid, and another drainage retinotomy from where I put in a soft tip. So there was an irrigation going on from one side, aspiration happening from the other side, and using a chandelier. It worked very well.
I will show a video of that. I have it. If that, I think time it. Please.
At one point, I was doing a diabetic vitrectomy. First, I did the worst eye, then the patient accepted to get the other eye operated. And there was a bleed operatively. I raised the pressure for less than a minute. The next day the patient was PL negative.
So you're talking now about diabetic vitrectomies and bleeding. I think I will be speaking on that. Probably we'll have the discussion after that on this topic. I'll be discussing all these important points. So now I think we can just focus on Dr. Ajay's presentation, which was occurring of a hemorrhage, of a submacular hemorrhage during vitrectomy, during an uncomplicated surgery. This I'll discuss in detail.
Yes,
Please.
yes, sir.
About removing the pre-retinal clots.
Pre-retinal or subretinal?
Pre-retinal or even in some cases subretinal, in case there is a retina detached. There is an instrument that I have designed called as aspiration scraper. A couple of years back it was Natarajan award winning paper. The thing with that, it's a diamond dusted cannula which has a bent tip, and you can actually where there is a clot which is stuck, you can gently scrape the clot off and then take it off the retinal surface. If it's a large clot, then you can cut it with a cutter, but it's easier to remove the clot from the which is densely adherent to the retina. So that works quite well. And even in subretinal area, you can create a relatively small retinopathy and go subretinally. Since it goes along the curvature of the globe, we can actually massage the subretinal area and remove the clot, and then it comes off much more easily.
Yeah, another
So-
thing, Manish, that is you can use a combination of a finesse loop with an aspiration. Now, finesse loop, if you see when you extend it, you get the entire finesse loop out. Now, if you do not extend it full, you get half. When you get half, the amount of force exerted by half finesse loop versus a full finesse loop is different. With just a tip of finesse loop pointing out, you can actually create an ILM peel. So you do not completely take it out, just a little bit. It is firm. Fully, it is not firm. So you want to remove the blood, take it out fully, take the finesse loop, aspirate, and have an active aspiration on the other side. Works beautifully.
With aspiration scraper, you do these things with single hand.
So
No, sir, you have a chandelier, you have one hand finesse loop and one hand
So,
aspiration.
sir, see, I think what you just mentioned is very good for a pre-retinal hemorrhage. But just for the audience, I just want to make it very clear, you should not go behind the blood and do a blind scraping in the submacular area.
You can, not submacular, but it's not blind. You can actually see what you are doing.
Okay. Because as I said, the best way for a
problem sir, anything trauma to retina should be minimal.
Yes.
Yes.
See, then sir, you may do surgical erosion by doing the retina.
If there is a clot subretinal that you want to take out, actually,
If it is submacular, we are talking different.
Yeah, that is submacular is the most important. That
Extramacular is not a big thing.
we can even leave it.
You just do retinopathy.
Exactly.
Generally, it comes out. And finish loop, may not finish loop. The problem is they have,
Yeah, they will-
they traumatize the retina more than.
Probably the choroid also can lead to hemorrhage, more hemorrhage. So
And so the
message
final is that one more simple way of aspirating all this blood is the simple back flush which we use,
Yeah, simple.
and not just partially cover the hole so that the aspiration is controlled, and then you can do it. It's a very
So
simple and
I'll
non-traumatic
show
way.
you. There's a big mathematical formula to calculate the amount of force generated by fluid within fluid in air. So I'll be presenting that tomorrow. When you do a back flush and push the fluid, and versus using the same fluid in air and hit any object, the force generated is totally different. So when you use a back flush, as Dr. Vishal said, in a subretinal space, you use minimal force, but it dislodges the clot and then aspirate.
So I think there are a lot of questions. Just to summarize, sir, I just want
Sir,
to
last-
make two points.
Excuse me, can I make a point? I had encountered a similar case of CNVM bleed. I was treating with an anti-VEGF therapy. CNVM bleed,
Yeah.
subretinal bleed. When I was treating with an anti-VEGF therapy, I landed up in a RD. So it was we planned to set the RD with the routine vitrectomy and all. I was wondering whether I should go back behind the retina and then touch that CNVM or remove the clot or not. Just I wanted to know how to tackle these kind of cases when the risk of rebleed when you touch the active CNVM is high, or whether to just settle the retina and leave it off, or you need to go back and then remove the blood clot as well during the vitrectomy.
So I personally feel that if you have an CNV which is bled, and it is causing an obstruction in the vision, you must first make sure that you've given your anti-VEGFs, because you have to control the CNVM. if the blood, if you follow the standard protocol, which we wait for some time for the blood to absorb on its own. Otherwise, we go ahead, do the vitrectomy, give anti-VEGFs. We used to, a long time back, create a retinotomy, remove the CNVM subretinally, causes a lot of scarring there. If you can just control it with anti-VEGFs, if it is extramacular, do a laser. I think that's what should be.
Mike.
What I would do is a very small hemorrhage, leave it and depend on pneumo-displacement.
Yeah.
At the end of the procedure, inject gas, and pneumo, that works the best.
Yeah.
That, in my hand, works the best for that.
So yes, sir, I think CNVM bleed are different stories, and if there is a CNVM with a large subretinal bleed, I think we have to do a vitrectomy. Then depending on your expertise, it also has been described that you can give a subretinal anti-VEGF along with a subretinal tissue plasminogen activator that will liquefy the blood, and then you can inject gas to displace it. So these are the ideal management for a large subretinal bleed. Again, if the subretinal bleed is small and does not require much intervention, probably only gas with anti-VEGF will be sufficient. So just to summarize what in Dr. Ajay's AURORA, just to get the get-home message, if you have a submacular bleed which is extramacular, I think you don't have to fight very much for it. As much you're comfortably able to remove it, you can make a retinotomy and remove it with the back flush. If there is a large submacular bleed, then it can lead to grave prognosis. That is the important part. First of all, you have to prevent it with liberal use of PFCL. And if it occurs, the best method is you have to create a retinectomy. You have to lift the retina and remove the clot. That is the most atraumatic way of without damaging the underlying retina and the choroid. And once the clot is removed, you can just proceed as a normal giant retinal tear surgery.